During the next 20-25 minutes, I will try to give you an overview on our current knowledge on peripheral tissue biopsies in Parkinson's disease as a source of a biomarker. As you are aware, there have been major advances for the detection of Parkinson's disease pathology at the end of the noughties, with the discovery that the neuronal protein alpha-synuclein is a main component of Lewy bodies and Lewy neurites. Since 1997, alpha-synuclein and phospho-alpha-synuclein immunostaining have therefore become the techniques of choice for the detection of Lewy bodies and Lewy neurites. This is why I'm going to use the term alpha-synuclein histopathology, ASH, and phospho-alpha-synuclein PASH histopathology for the rest of this talk. Using alpha-synuclein and phospho-alpha-synuclein immunostaining, it has been now clearly shown that the presence of Parkinson's disease pathology is more frequent and more widespread than initially realized. Alpha-synuclein and phospho-alpha-synuclein histopathology are found in the peripheral autonomic networks in a large proportion of PD patients. On the left part of this slide, you see, for example, PASH deposits in the colon of a PD subject. That's a picture taken from our lab, with a Lewy-like Lewy body-like aspect on the lower panel and the Lewy neuroid-like aspect in the upper panel. Quite remarkably, some of these peripheral neuronal networks that are affected by ASH and PASH are accessible to biopsies. This is, of course, true for the skin, the salivary glands, and the GI tract. This provides new opportunities for the development of original biomarkers that will directly assess the pathological process in living subjects with Parkinson's disease. Most studies used alpha-synuclein and phospho-alpha-synuclein immunohistochemistry for the detection of pathological alpha-synuclein. So let's start with the skin. That's a trendy topic, so maybe it's nice to start with the skin. The first paper that was published on the topic was published in 2009, and it was Japanese studies. And to be honest, it was a bit disappointing because, as you see, using two biopsies on the chest and on the leg, this group only found phospho-alpha-synuclein immunohistopathology in 2 out of 20 PD patients. It was not only until 2014 that two independent groups, one from Germany, the other one from Italy, convincingly showed that skin biopsies allowed to detect PASH with an acceptable sensitivity and a very good and excellent specificity. These two teams used skin biopsies at multiple sites and a biopsy processing that was different from the one that was used by the Japanese group in order to get these positive results. Please note that the more proximal the biopsies, the higher was the sensitivity. There is no need to mention that since then, the analysis of ESH and PSH using skin biopsies has become a very trendy topic. More than 25 studies have been carried out and published on the use of skin biopsies for the detection of Parkinson's disease pathology. Most of this study reported ASH and PSH with a high specificity, almost 100% versus control, and good sensitivity ranging from 55 to 100%. It should be mentioned that a couple of studies did not succeed in the detection of pathological alpha-synuclein, or they reported a low sensitivity. And this discrepancy, such a discrepancy, might be explained by some technical issues and technical differences. For instance, the depth of the biopsies, the diameter of the biopsies, the site of the biopsy are all different between the studies. And it seems that the critical aspect could be the fixation of the biopsy. And for example, fixation with the Zamboni preservative along with cryosection is likely to be the best approach in terms of sensitivity. So let's move on to the salivary gland biopsies. Autopsy studies have consistently shown that the submandibular glands, here in red, are affected by the Lewy pathology, so pathological process in PD, in almost all PD patients who were analyzed. This explains why most of the existing studies on salivary glands in living subjects have focused on these submandibular glands. The seminal paper on this topic was published in 2014 by the group of Charles Adler and Thomas Beach. And so they performed submandibular gland biopsies in 15 PD patients with a full-blown disorder, and they found PSH in 9 out of 15 subjects. It should be mentioned that they were unable to get and to retrieve tissues in 3 cases. They further confirm these findings in several subsequent studies, and more recently, a Korean group also showed that it was possible to detect ASH or PSH using this approach. The minor salivary glands are more easily accessible than the submandibular glands in the clinical practice. This logically led us to analyze the minor salivary glands for the presence of PSH in PD patients. That's something we did a few years ago in the lab. And you see that the results were, again, a bit disappointing because we were only able to identify a positive staining in only 3 out of 16 PD patients. And I didn't mention that on the slide, but since then, 6 studies use a similar approach, and they gave conflicting results. So I'm not sure that this is a very promising tool. So might be better to focus on the submandibular glands. And so I have saved the best for last. And of course, I will talk about GI biopsies. Let's begin with a critical point, critical aspect. If you want to analyze the enteric nervous system, and especially the submucosal plexus properly, what you've got to do is to dissect the biopsy. The biopsy doesn't have to be paraffin embedded. This is what you see on this video. Emmanuel Coron is our gastroenterologist. He's taking biopsies during the course of colonoscopy. And then the biopsy, you see, is not fixed, but just a few minutes after the procedure, the biopsy is dissected. And the epithelium is peeled off. And then you get access to the submucosal plexus. You see it's peeled off with watchmaker forceps, and you see this black mesh, this black network. That's a submucosal plexus. That's the inner part of the enteric nervous system. And if you stain these biopsies with a neuronal marker, this is what you get. You get a very nice neural network with a ganglion, antiganglionid fibers, and you can perform a in-depth and comprehensive analysis of the enteric network, and especially perform some neuronal counting. Of course, this approach can be used for the detection of PASH in Parkinson's disease. When we used such an approach in PD patients, you see in 29 PD patients, we were able to detect phospho-alpha-synuclein PASH histopathology in 21 out of 29 PD patients. It was quite specific because not observed in controls. And we confirmed these findings in subsequent studies from the lab. This dissection Allmont approach is especially helpful for the analysis of the enteric nervous system. See, you've got some nice ganglion. Again, you can perform some neuronal counting. So it's let's say quite elegant, but it has nevertheless some limitations. As you saw previously, the biopsy must be dissected immediately after the endoscopic procedures. It requires an experienced technician, and you can't do any retrospective analysis of your biopsies. In this regard, it might be easier and maybe more relevant to use formalin-fixed paraffin-embedded biopsies, which are available in most hospital-based laboratories. And as you know, these sort of biopsies allow to perform retrospective analysis. So not only our group, but let's say in a collaborative project, when we perform a multi-center study with 4 different experts who use optimized immunohistochemistry methods for the detection of pathological alpha-synuclein in paraffin-embedded biopsies, all stainings, regardless of the lab, were unable to discriminate between PD and controls. This is an example you see on this slide. You see this is a small staining, which might be similar or yes, or not too different from Lewin-White. Of course, you got this in the PD subject, but also in the controls. So it is likely to be a false staining and a wrong staining due to the epithelium. But again, it doesn't work for the discrimination between PD and controls. So maybe a bit tricky to use these formalin-fixed paraffin-embedded biopsies for the detection of Lewy pathology in GI biopsies. So if we try to summarize the pros and cons of each biopsy site, we can say that the skin has several advantages, provided that the biopsies are properly processed with cryosection. The sensitivity and the specificity are acceptable, or let's say pretty good. And as you easily guess, the skin biopsies can be easily and repeatedly performed. It should be borne in mind that in contrast to the skin subarachnoid glands biopsies, the GI tracts allow to analyze an integrative neuronal network, not only neuronal processes, but cell bodies of the whole submucosal plexus. So this might be a plus for the GI tract. 2 additional questions. The first one, can ESH, PASH in peripheral tissues detect premotor Parkinson's disease? This is still a bit debated, but there are a few studies on the topic, and the answer is most likely yes, because a few studies have been carried out in subjects with REM sleep behavior disorder, and the presence of alpha-synuclein deposit has been observed in the skin of RBD subjects, and a paper published by a Spanish group in the Lancet Neurology showed that it was also possible to use submandibular glands to detect Lewy pathology at an early stage in peripheral tissues. And the second question is PSH specific for PDs? What we can say is that in several studies it has been shown that it is negative in tauopathies. For example, you don't get any, it's quite logical, we don't think about that. You don't get any alpha-synuclein deposits in patients with PSP. And it's definitely beyond the scope of this talk, but let's say that it's still debated in MSA. Some people say that there may be something in the skin, but again, it's beyond the scope. So what's next? What's the future? I think that you saw in the previous slides that also interesting, the results obtained with alpha-synuclein or phospho-alpha-synuclein immunostaining are sometimes a bit dubious and a bit delicate, a bit tricky to interpret. I know it's not, especially for the GI tract, sometimes it's quite difficult to be sure about what is physiology and what is pathological. So there are some novel approaches that may be really helpful. For instance, and this new approach is called PMCA for protein misfolding cyclic amplification, or RT-QuIC, are based on the fact that if you've got a very small amounts of pathological alpha-synuclein and a large amount of soluble alpha-synuclein, then if you sonicate and shake the samples, then you will get a lot of oligomers, and monomers will turn into oligomers, and you will be able to quantify the amount of monomer in using pureflavin T fluorescence, and it gives a black or white result. So there's no discussion about the aspect and about the staining. It is positive or negative. You've got a level of fluorescence, and this kind of approaches have been used in GI tract biopsies. That's something we did in the lab in collaboration with Ronald Melky, and it worked pretty well regarding specificity and sensitivity. And a couple of recent papers show that it seems also to be a promising tool for the detection of pathological alpha-synuclein in the skin biopsies or submandibular gland biopsies. So I think it's very interesting for the future. This is going to be my last slide. I don't know, but if you are interested by the topic, I think there are some, let's say, pretty good reviews on the subject. The first one is a German one published a few years ago, and it was about the use of GI tract, skin, and submandibular gland biopsies for the diagnosis of PD. We published something a few years ago that was focused on the GI biopsies, and there was a very nice and comprehensive review by Dr. Doppler from Würzburg that has been published a few days ago in GPD. Thank you very much.